Hello, everyone. What I'm going to present today is how to manage antiretroviral treatment failure. So here is my disclosure. So this is the outlines of my talk. I'm going to cover how we're going to define biological failure, then how we're going to evaluate the patient with antiretroviral treatment failure. Then I will update or refresh all of us again about the principle of HIV drug resistance and the genotypic drug resistance testing, how to select the next treatment option, and then the summary. To define the biological failure, the arbitrary cutoff is a 200 copy of HIV RNA in the plasma per ml. To confirm that it's a biological failure, so we will do a two sequential tests to confirm if the biological load, the viral load is higher than 200 copy per ml. We consider as a confirmed biological failure. In case of low level viremia, the definition is mean that the patients have the viral load level in between 50 to less than 200 copy. In case of confirmed biological failure, there are two scenarios. The first scenario is a failure to suppress. So it means we cannot have viral suppression below 50 copy since the beginning. The cause of this failure to suppress in general, the most common is related to HIV drug resistant transmission. The second more common scenario is the patient has been well suppressed for a certain period of times and then become a biological rebound above 200 copy per ml. And this most commonly related to poor adherence, and some also related to suboptimal dose of the ARV related to drug interaction. When we have a patient with defined or confirmed biological failure, so we should perform HIV genotype resistant testing. In this case, is what we call the plasma HIV RNA genotypic test. In general, most of the tests will be sensitive when the viral load above 1,000 copy per ml. But in some particular setting, they might be able to pick up, again, less sensitive at the level of 500 copy per ml. And we should perform the test while the patient still taking ARV, that particular regimen, or has been stopped but less than or within 4 weeks. Now, there are quite a number of key factors that associated with biological failure, either by the virus itself, because we got a transmitted resistant virus, or super infected with drug-resistant virus from the partner, or because of the drugs, suboptimal potencies, or tolerability issue, or we using low barrier to resistant treatment option. One thing that we might be we might not really appreciate or forgot to appreciate is the healthcare worker services. We definitely need to have a good attitude. We need to continuing support our patients to motivate them and support them. And we also have to be aware about the drug-drug interaction. Patient's factor is the most common cause, actually, that associate with biological failure in terms of non-adherence or intermittent adherence and other social factors. In many cases, it's not only one factor, it can be a complex factors, and we have to address and assess it carefully. So when we're seeing a patient with antiretroviral failure, we will start assessing that individuals in terms of the history of adherence, the past history of ART treatment, history of HIV drug resistance, if there's any, possible transmitted drug resistance, we might explore about the history of the partner. Don't forget to, and it's very critical in some cases, to explore the potential drug-drug interaction and other social factor and the patient's clinical status in terms of comorbidity and the current viral load and CD4. The higher viral load and very low CD4, we also associate with treatment failure. Then we will select the next option based on genotypic guidance and to see how many available treatment options we can offer to the patient. Ideally, we should include 3 active ARV in the new regimen, or at least 2 active ARVs, preferably the one with high genetic barrier to resistance. Now come to the taking the history. So what type regimen they are currently taking right now, or is there any other previous treatment history or not? Now, I think we're all familiar that currently we have 4 classes of ARV commonly used as an oral treatment option. The nucleoside reverse transcriptase inhibitors, integrase inhibitors, protease inhibitors, and non-nucleoside reverse transcriptase inhibitors. The current guideline, both from the US DSSS, the IAS, the European guideline, the British guideline, and for most low and middle income countries, we will commonly follow WHO guideline. You can see that integrase inhibitor is the most preferred regimens. So how to formulate a regimen, so we call it triple regimens. So this is the principle to make it easy to understand or to get into the principles. You see that we select 2 of non-nucleoside, 2 of the nucleoside reverse transcriptase inhibitor, 1 from this group, either TAF, TDF, or Bacavir, plus FTC or 3TC. And then 1 from the second class, the other class of ARV, integrase inhibitors or protease inhibitor or NNRTI. That I mentioned earlier that most of the international, including WHO guideline, prefer integrase inhibitors, particularly DTG and Bictegravir, dolutegravir and Bictegravir. Now let's refresh us again about the principle of HIV drug resistance. So we can simply classify the resistant pattern into 2 genetics: barrier to resistance, or high and low. Low genetics barrier is mean that the RV that require only a single mutation or what we call the resistant associated mutation, can lead to a high level of drug resistance. These are the common examples in NRTI, particularly the first generation, nevarapine, efavirenz, lamivudine 3TC or FTC, larticavir in the integrase inhibitor group. High genetic barrier to resistance means that particular ARV requires several mutations to become high-level drug resistant to and that particular ARV. In this case, dolutegravir, bictegravir, and boosted PI, in particularly darunavir boosted. Now this, to give you more example based on the Stanford database. You can see that M184V associated with only single mutation associated with high level resistant 3TC or FTC. K103N or Y181C, a single mutation associated with high level resistance to first generation non-nucleoside reverse transcriptase inhibitor, in this case, efavirenz or nevarapine. Within the same class, in this case, integrase inhibitors, there are two ARV in this class, larticavir, elviticavir, we consider as a low genetic barrier to resistance. In this case, you see that if the virus develop Q104H or N155H, will associate with a high level resistance to larticavir or elviticavir. In contrast to the second generation integrase inhibitor, dolutegravir and bictegravir, it requires up to 3 or more mutation to develop high level resistance to DTG or bictegravir. The other factors that also will lead to a higher risk of drug resistance in terms of pharmacokinetic profile of that particular ARV regimen. In this case, the big concern is the long pharmacokinetic tails of an NRTI. It's a risk of HIV drug resistance in addition to the low genetic resistance barrier. You can see here that if you prescribe TDF-FTC plus NNRTI, either efavirenz, nevarapine, or rilpivirine, if the patient missing at the dose of the next day, you can see that the shorter half-life, an average about 1 day of nucleoside backbone will be gone. In contrast, the NNRTI with the long tail pharmacokinetic will remain detectable in the blood and tissue more than days or weeks, so that increase a higher risk of developing drug resistance because of the low genetic resistance barrier. In contrast, if we prescribing a regimen of triple drug regimen with a similar pharmacokinetic profile, in this case, 2 NUCs with integrase inhibitors or 2 NUCs with boosted PI, you can see that the kinetics tail are so similar that will allow more forgiveness in less adherent person. So the other factor that also affects or impact on the treatment outcome of virological failure is the pre-treatment HIV drug resistant or transmitted HIV drug resistant. This is the recent published data from the WHO drug resistance surveillance back in 2014 to 2020, have done in 30 low and middle income countries. So look at the prevalence of pre-treatment HIV drug resistant. Overall, globally, in these surveys, the good news is that resistant to any drugs, ARV, before getting ARV treatment is less than 10%. However, there's a lot of variation between regions. In America and Africa, is there the detection of pre-treatment drug resistant prevalence is higher than 10%, whereas other regions like Asia and Pacific, Southeast Asia have less than 10%. In terms of the drug class, NNRTI have the highest prevalence, 7%. The good news is that the commonly used backbone, TDF and FTC, 2TC is less than 2%, and DTG is less than 1%. Now, when the data look at the key population, this is another systematic review and meta-analysis study with these total number of patients, more than 60,000 from 218 studies. This is a pool preference estimation of any pre-treatment drug resistant found in different key populations. So the highest in the key population in terms of preference about is and 17 to 18% in sex worker or people in prison, and followed by 13% in MSM and 7% in people who inject drugs. This study published 3 years ago also very interesting to show that pre-treatment drug resistant, even with different class, in this case in liver transcriptase, also can compromise the first line option with integrase inhibitor as a first line. You can see that from this study, 14% has at least one mutation detected before starting first line. Almost 100% related to NNRTI drug resistant. And when they look at the patients with regardless of adherence with pre-treatment drug resistant, what they found is lower, so 65% success rate of biological control compared with 85% of patients without pre-treatment drug resistant. And this pattern is similar when you look at efavirenz-based treatment or DTG-based treatment. And to look at the figure, I'd like to emphasize once again, even in highly adhered patients, more than 95% adherence and treated with dolutegravir-based ART, you look at without pre-treatment drug resistant and with, so the response rate is really different. Now, how are we going to treat NNRTI failure? Some ARV may be recycled. In this case, 3TC, darunavir booster, or second generation integrase inhibitor, particularly DTG. However, for DTG and dolutegravir should be increased the dose to achieve drug concentration in patients that have relevant resistant mutation. This is one study to show that whether we have to double DTG dose in patient failed NNRTI. Keep in mind that the median baseline of this population is less than 10,000 copies. So although up to 80% of this group of patients has both TDF and 3TC drug resistance, at 24 weeks of the treatment results with TLD, either adding another tablet of DTG, doubling the dose of DTG on top of TDF, lamivudine, DTG, or just standard dose of DTG, the results of success rate at 24 weeks by undetectable viral loss is similar. And interestingly, none of the 6 participants, 3 from each arm, that eligible for resistant testing who have virological failure didn't detect any drug resistance against dolutegravir. So how to manage integrase inhibitor failure as the first line? This is the option of integrase inhibitor that either, so in the high-income countries, they prefer single tablets of bictegravir, TDF, TAF, and FTC. In low-income countries, including Thailand, we prefer single tablet of TAF, FTC, and DTG. Again, I like to emphasize again that resistance is extremely rare in the integrase first-line treatment failure, particularly DTG or bictegravir. Now, this is study also shown in the switch study of NEAT 022 study. Look at the 96-week results with the sample size about 400 individuals randomized to immediate switch to DTG in well-suppressed patient. Patient has been on boosted PI and very well suppressed, or defer DTG. And you look at the result at week 96. So up to 90% or above 90% of both arms have virological success. And again, resistance in the treatment failure of these 10 individuals is not or are not detectable. So again, resistance in virological failure patient to DTG-based regimens is rare. However, adherence does matter in DTG-based ART. So in this study, they pool the data from Gemini 1 and Gemini 2 together. So this 2 study actually is a randomized control study comparing 2 drugs, DTG, 3TC versus 3 drugs, DTG, FTC, and TDF. And you look at among 5% of these participants has less than 90% adherence. And when they look at this lower adherence population, the response rate of both arms is less than 70%. However, because as I mentioned that this is related to intermittent adherence problem, so when they confirm adherence and retest this again, it's about 90% people be able to control the virus. In contrast to those with well adherence, at least 90% or more, you see that it's more than 90% of patients has virological well control. And be aware of the drug interaction with cation, and particularly calcium, iron, magnesium, and aluminum. And so make sure that for calcium and iron containing multivitamin need to be taken with food together with dolutegravir or bictegravir. For the antacid containing aluminum and magnesium should be taken 2 hours before or 6 hours after. So ultimate goal is, again, to suppress virological viral load below the limit of detection. And that means we need at least 2 active drugs. The good news is that this is data from Europe that the trend of 3 or 4 class drug failure is declining significantly. So the new option for HIV multi-drug resistant is a good news that there's a new class. In this case, is capsid inhibitor, has been recently approved by the FDA. These capsid inhibitor have been shown that in phase 2 that have 80% or more virological suppression below 50 copies per ml. Now, I'd like to highlight here about treating patients with multi-class ARV failure. So the first thing is the potential success factor depend on a new number of new active drug in the regimen, the potency of new ARV, again, multi-drug resistant. Baseline viral load ideally should be below 100,000 copies, and CD4 should be better than 100. And of course, patient adherence and drug tolerability also a key factor. So to conclude this presentation, early detection of virological failure are critical to preserve the next treatment option. The good news is that DTG-based regimen failure, the first-line failure, has a very rare chance to develop drug resistance. So promptly address adherence, drug-drug interaction, and other risk factors will lead to a viral resuppression again. Selecting a new regimen for treatment failure is also an individualized approach based on history taking and other factors that I have been mentioned. So to aim for a durable resuppression, the new regimen should ideally consist of 3 active drugs or at least 2 active drugs. Thank you very much for your kind attention.